In this Lancet Child and Adolescent Health Special Commission on delivering transformative action in pediatric pain, we brought together an international team of experts in pediatric pain, including patient partners, academics, scientists, and policy experts. And we tasked them to think about what our focus should be in 2030 in pediatric pain science, practice, and policy. Far-reaching discussions and a tremendous amount of work putting together this commission, we focused on 4 transformative actions, 4 goals to deliver change in pediatric pain. They are to make pain matter, to make pain understood, to make pain visible, and to make pain better.
Our first transformative goal is to make pain matter. Pain is a really personal experience. It's often invisible, and that can make it really easy for others to dismiss or to minimize it. And that's particularly true for children who can't talk, like infants. And we often think that pain is short term, which somehow means that it's not important or it doesn't have a long lasting impact, when even something like a painful, brief procedure like a needle can be traumatic, especially if it's done without proper pain care. In some cases, we already know how to address all of this. And really, our efforts need to be on making sure that the science gets into the hands of people who can use it every day more effectively. But there's lots we still don't know. Pain relief is a fundamental human right, yet there are many children and families that face inequities, stigma, and poor access to adequate pain care.
Pain is a complex sensory and emotional experience that cannot be seen as either purely physical or all in the mind. These two aspects are closely interlinked, and this is very clear from the complex pattern of brain regions that are activated or altered by pain at all ages. Somatosensory nerves transmit noxious signals from the periphery to the brain, but sensitivity and the ability to modulate pain at different sites along the pathway changes throughout postnatal development. In its most familiar form, acute nociceptive pain is protective, warns us of tissue injury, and resolves with healing. However, ongoing pain input or injury affecting somatosensory nerves resulting in neuropathic pain can alter the balance between endogenous excitatory and inhibitory mechanisms and lead to sensitization. And nociplastic pain can persist even in the absence of clear evidence of active disease or injury. Pain is not a one-size-fits-all experience, even for those with the same disease or injury or type of surgery. Multiple factors contribute to individual variability, including age, biological sex as well as gender, genetics, coping style, context, and prior experience. Associated differences in either vulnerability or resilience can influence the severity and experience of pain and also the risk of transition from an acute to chronic pain state. Pain during critical periods of nervous system development can produce changes in sensory processing that differ from those seen after the same injury at older ages. A wide range of physical, environmental, and psychosocial stresses and adversities during childhood can also influence health and well-being in later life. Pain is a personal and internal experience that needs to be made visible to inform management. There are obvious challenges in neonates and pre-verbal children who cannot self-report their symptoms, but even in older children, proxy measures and assumptions based on behaviour alone can be inaccurate. Pain intensity can and should be measured in children with tools that are valid and appropriate for the developmental stage of the child and the clinical and social context. However, assessing pain is much more than measuring intensity alone. Core outcome sets need to encompass factors relevant to a range of stakeholders, and this can include patient and parent-reported outcome measures that identify clinically meaningful changes in physical, emotional, and social function, biomarkers that are valid, sensitive, and specific for use in research and clinical trials, measures of healthcare utilisation and economics that are of importance for healthcare provision, and crucially also include measures and outcomes that are important and relevant for both patients and their families. Harnessing novel information technologies, will improve collection of large cross-sectional and longitudinal data sets to make population patterns, changes with time, and the acute and long-term impact of pain in childhood more visible.
Our fourth transformative goal is to make pain better. We have enough knowledge and science to know that it's no longer acceptable or ethical for a child to be in pain and do nothing about it. But there are still gaps. Although medications are commonly asked for and commonly used, there's a shocking absence of evidence to tell us when and how to use them with which kids. We also haven't focused enough on how to prevent chronic pain or how to use new technologies like virtual care. And most importantly, we have to remember, we have to embrace that pain is complicated. We need to tailor what's needed to each child and each family. One size is not going to fit all. And that we need to involve children and parents as partners in the child's care as a critical step to overcoming this. Despite decades of pain research, there's still work to be done. These four goals have to be addressed all together. If you're a child, a parent or a caregiver, a family member, a clinician, a policymaker, a health research funder, a health executive, or a researcher, join us. We all have a role to deliver transformative action in pediatric pain.